Osteoarthritis is a synovial joint disorder which is triggered by damage and repair processes. Joint damage can result from repeated stress or injury. And most common forms of arthritis affect the knee, the hip joints, and the small hand joints. So there's a variable presentation between individuals and joint sites, but typical features involve localized cartilage loss, bone remodeling, osteophyte formation, and mild synovitis. Risk factors, so genetic factors, so 40 to 60% heritability for hand, knee, and hip osteoarthritis is present. Biological factors include aging, first and foremost, female sex, obesity, high or low bone mineral density, joint injury, and occupational stresses. So diagnosis should be suspected in individuals who are over the age of 45 or older with typical features present. And there may be a history of activity-related joint pain with no morning stiffness lasting over 30 minutes and functional impairment. Examination findings, so you may find bony swelling, joint deformity, instability or effusion uncommonly, joint warmth and or tenderness, muscle wasting, weakness, restricted and painful joint movement, and crepitus may be present. Assessment should involve evaluation of reported pain, stiffness, functional impairment, psychosocial impact, self-help strategies, comorbidities, and social support. So investigations, a routine x-ray may not be required, but is often done. Clinical examination is primary, so x-rays for advanced cases. Body weight and BMI recording is important. MRI for distinguishing other causes where diagnostic uncertainty exists. And blood tests are normally normal, but consider a baseline FBC, creatinine, and LFTs. Management. So there's a holistic approach to management, considering function, quality of life, mood, and relationships. Core treatments involve therapeutic exercise, weight management, education and advice, and drug treatments such as paracetamol, topical NSAIDs, oral NSAIDs, which may be used with caution, particularly in elderly. Opiates may rarely be used. Glucosamine is not recommended. Intra-articular corticosteroid injections are generally used for short-term symptomatic relief, particularly where there's acute inflammation, and referral for joint surgery if the non-surgical options are ineffective. Emerging treatments include magnetic resonance therapy and genicular artery embolization, which are under research, but there's limited evidence for efficacy. These patients should be referred to the MDT, the multidisciplinary team, including physiotherapists for exercise advice and joint supports, occupational therapists for assistive devices, podiatry for biomechanical assessment and footwear advice, orthopedic surgery for consideration of joint replacement, pain clinics where specialist pain management is required, and psychological services for anxiety and depression management.